This is your learning objectives. So we're also going to talk about the fact that the skin lesions can be infected, and they can be either bacterial, fungal, or viral, and that cultures need to be done to determine what is causing the issue. Assessment of the lesions itself is important, looking for evidence of infection, and teaching the child not to touch or scratch any of the lesions to actually cause an infection or make the infection worse. So we're starting with head lice, and interesting enough is head lice is very, very common in children. And generally speaking, when people or children are very, very close to each other, the head lice actually will go from one child to another. We see it frequently in the younger grades in classrooms or daycares, see it in school age. And a lot of times it is shared or transferred by children sharing anything that touches their head, such as a comb, a brush, a headband, a hat. The female lays eggs, which are called nits, at the hair shaft, close to the scalp. And they are little white, oily, teardrop-shaped masses that you cannot pull off with your hands. These eggs, or nits, will hatch in about 7 to 10 days. Meanwhile, the head lice is sucking the blood off the host. And by doing that, just like a mosquito bite, it becomes very, very pruritic. And they say it's caused by an allergic immune response. When children have lice, they usually have about 20 lice in their head or more, and then several nits per each head lice. Head lice are the adult lice. Many times, if you look at the nape of their neck, there'll be the little red bites, but if you look closely, there'll be several marks on their head that have red bites, but they also have the black dots in it, which is the lice feces. Living on the human head, the female can live about 1 month. So people usually freak out with this, including nurses, and it's important to tell the people that we know that anybody can get head lice. It's kind of common. Doesn't necessarily mean that they live in a dirty environment. It's important for the nurse to inspect the hair carefully, going from the nape of the neck up, and to identify any live lice or any nits. The child should be given an anti-lice product to use, and then their hair needs to be combed for the nits afterwards. It's called a nit comb. Meanwhile, a good discussion can, prevail about not sharing any head gear, if you want to call it that. Once the head is washed with the special shampoo, a repeat treatment is done 7 to 10 days later, and again the nit comb is used. All members in the house should be treated. All linens, towels, underwears, and clothing should be washed in hot water, and the dryer should be put on the hot cycle. Anything that cannot be washed needs to be sealed in a plastic bag for 2 weeks. There is special spray you can get for furniture and carpets, but what's mostly important is to vacuum all carpets, car seats, pillows, any furniture, stuffed animals, and put them, and then change the vacuum cleaner bag, and put that in a plastic sealed bag. And combs and brushes or hair items should be soaked in a lice killing agent for about 1 hour. So the description of the head lice is on this page, and the description of the medication or the shampoo is also listed. Each one's a little bit different. These shampoos can be a little bit toxic to children under 2 years old. So this needs to be discussed with the physician on whether these younger children can have any of these products. When the hair is shampooed, they should not use a hair dryer on the hair or a curling iron. It should dry naturally. And it's suggested that the parent cover the pillows with a towel to keep the medication from staining the pillows. There's several listed here. Some of them are over the counter and some of them are not. For instance, the methionine, I believe, is a prescription. With the methionine, which is one that's used kind of often, the medication is put on the hair uncovered and left there for 8 to 12 hours. It's more like a cream that's put on the child's hair. They wash the hair with this cream and leave it on for 8 to 12 hours. Then between 8 and 12 hours, they can go ahead and thoroughly shampoo the hair and then use the knit comb and get any of the knits out. All of these products, the directions are on the product and they should be followed exactly. If the child has some kind of nits and lice that are resistant to the over-the-counter products, this ivermectin can be used. It's a prescription, can be used, but the doctor, needs to discuss it with the patient. It's very, very expensive. It's not used often because it can be toxic to young children. All of the other products listed here need to be used, and then 10 to 14 days later, they need to be repeated. We talked a little bit already about pinworms, that the child swallows the eggs, they live in the colon, and they can live, in the colon for a long time. And during sleep, the eggs hatch and the female pinworm leaves the intestines and lay the eggs right on the edge of the rectum. The child will have intense itching and it kind of makes them crabby. They don't sleep well, they're restless, and it can cause enuresis. It's, the contributing factors is usually schools and daycares. So there's a couple ways we can do the tape test. It needs to be done 3 days in a row. One way is to put the clear Scotch tape on the child's anus at bedtime in the shape of an X. Take it off in the morning and place it in some kind of container and take it to the lab for them to look for under the microscope for the actual pinworms. The other way that could be done is the parent or you can press the clear tape against the skin of the anus right first thing in the morning and look for the eggs because it should stick to the tape. And once again, it needs to be done 3 days in a row and taken to the lab each day. It's important to talk about good hand washing, not putting their hands in their mouth, not biting their nails. And once we know the child has the pinworms, they should actually undress in the bathtubs so that they're not shaking their clothes all over the floor. All their clothes and bed sheets and towels need to be washed in hot water. The child should shower during this time instead of bathing so that the pinworms don't adhere to the tub and then someone else gets in. The medication that can be given is listed here, and you give 1 dose when it's a positive pinworm test, and then another dose about 2 weeks later. And all members of the family should be treated. Scabies are interesting. They're little mites that burrow. Generally, they burrow up the leg or wherever the child touched another child that has a mite. But if for some reason this child got it like from a grassy area, the little scabies mite will just burrow themselves right up the leg. It's usually linear. There'll be a little black dot at the end of the track where the mother deposits their eggs. A real good description of it is a thin pencil mark lines on the skin. It's very itchy to the child. In fact, some of the lesions actually look like chickenpox, and with them being so itchy, people sometimes think their kids have chickenpox. The younger children will have it on the head, neck, shoulder, palms, and soles, but older kids, it's sometimes the hands, wrists, genitals, and abdomen. So a topical cream is applied. It's a medication from the head to the toes, and it's left on for 8 to 14 hours. The longer it stays on, the better, of course, it is for killing the scabies. Then the child can shower, but it needs to be repeated in 1 to 2 weeks. And anyone who's in contact with this child should also be treated. Once again, all the clothes, underwear, towels, and bedding should be washed in hot water. Sometimes this elamite is kind of, it burns a little bit. So you just, after it's on 15 or 20 minutes, it'll stop burning. And the child may still be itchy after the first application, so calamine lotion can be given. Impetigo is kind of familiar to everybody. It's usually a staph infection. It can be a strep infection, but usually we see it as staph. It spreads easily by direct contact. It's very itchy. Sometimes we see it when kids are constantly like rubbing their face, like little kids have runny nose, constantly like wiping sideways, and you'll see a little streak of little red like blistery things. We see it a lot around the mouth, and with little kids it can be anywhere. If a child has an open sore and he's playing with another kid that does have impetigo blisters and the blister has popped and there's drainage, that child with the little lesion will probably get it as well. Personal items that are shared can also transmit impetigo, causing the bacteria, and that's kind of newer information actually. So topical antibacterial or triple antibiotic ointment is usually put on it. There is one topical antibacterial that is actually a prescription. Many times if it's severe, the child will get oral antibiotics. Strict contact precautions need to be taken. This child, if he needs to be around someone else, the area with the impetigo should be covered. Otherwise, we don't really promote covering it. But if he, there's another little child in the home or whatever, we want to keep it covered. Good hand washing is important. The child should not scratch the lesion, so the nails should be kept short. And you have to teach that to the child and anyone else around that it's contagious. And personal items should not be shared, such as towels or clothes. So the picture on the left is impetigo contagiosus. And this is really, it's a nasty looking picture, but this is really a typical picture. So it starts off as a red macule, and then they turn into vesicles like little blisters and they rupture. And then we see the thick amber color exudate. So think of impetigo and honey-colored crusts. Even if it's a tiny lesion, you'll see a honey-colored crust. That goes hand in hand. There is the other kind of impetigo, which is a bullous impetigo, and that causes these yucky, large blisters. And this is really typical looking, although the book said that they could be clear. And we see them sometimes on extremities. They might have, gotten hurt by thorns or whatever and got some type of a bacteria, staph, or strep in it. And this one is a little bit more painful than itchy. The first one's more pruritic. And then warts. Warts are usually benign, and they're usually in the epidermis. HPV is usually the cause of the infection. And there's all different kinds of warts you can see. Usually it can be transmitted by touch, and the child may not develop the wart right away, but 2 to 6 months is typical after they've been exposed to the warts. The normal warts that you might see on the hands or the feet are harmless, and they will disappear on their own, but it does take about 2 years. So many times the families want these warts treated. So the treatment is on the right, you know, the cryotherapy, the entiretity, the salicylic acid. Sometimes, if it's really bad, the doctors will cut, this is extreme, cut away the wart, and they'll do some deep freezing of it. Laser surgery can help, and over-the-counter medications can help. I lost my train of thought. You can now buy the little packet to actually use to freeze off the warts yourself in the store. It's not quite as good as you'll get in a physician's office, but if the treatment is, done more than one time and done regularly, the warts will dissipate. The one thing I wanted to tell you is the entiretity. The other name of it is called Beetlejuice, and it actually puts a little blister around the wart, and then we put a Band-Aid on the wart and leave it on for 24 hours, and then take the Band-Aid off, and the blister will actually lift the little wart right off of the skin. This picture of a planter's wart on the foot. Now this one sometimes is painful because you're putting pressure on it. It's also treated with the over-the-counter medications. It's suggested that these kids get insoles that have little holes in it to decrease the pressure in that area. Every time one of the products is used, it's usually either done 24 hours or 48 hours, depending on what it says. The child needs to soak the affected area for 20 minutes prior to reapplying the products. And then genital warts, I just wanted to mention it since it's in this category. We don't see it in young children. In fact, we usually don't even see it in adolescents. It's something a little bit older we see. But it is very, very contagious. And there's a printout on the Gardasil, the immunization that can be given, and I put the website there, and I'd like you to print that out and read that and know a little bit about it. Mollusca, another name for it that you may know is the water warts, and it's not truly a wart. It's caused by the pox virus, and it is mostly spread by direct contact, but we see it a lot in warm water, pools or baths. Kids on swim teams get this often, and they get it on their back often. An individual lesion can last 2 months to 18 months. It will go away by itself once again. Usually people want it to go away because, especially if they're on the swim team. Most of the time the kids have no symptoms. Occasionally you'll hear someone complain about itchiness of it. Once it does heal, there will be the little tiny pits. It's really contagious, and if one child has it, they should not swim or bathe with other children because it will spread the lesions. The same treatment can be done for these lesions as what's done for warts, and they all work well. It depends on what area they're in. Sometimes the back skin of a child's pretty thin, So putting some of these products on it might burn the child a little bit. And then Lyme disease. It occurs by a deer tick biting a child. And unfortunately, the deer tick is so tiny that nobody really can see it. So if children are in wooded areas, especially places like up north, like Wisconsin or Minnesota, they should actually wear long, sleeves and long pants and protect themselves from these deer ticks. However, between 3 and 30 days, that little red mark that's known, as Lyme disease, will appear, and it might be small, and it might be in an area that people don't notice. They call it a multiple ring-shaped rash. And then shortly after that, the flu symptoms appear. The child appears to have the flu. If the rash isn't noted, the Lyme disease will progress. And it can, weeks to months later, affect the nervous system and can cause some weakness and paralysis of the facial muscles. We also have seen it affect the heart and cause inflammation of the heart. And occasionally, inflammation of the eyes has been an issue. If it's still not diagnosed, months to years later, the patient will have cardiac or neurological and or musculoskeletal involvement, and then it's pretty serious. It can cause some arthritis issues, deafness, and encephalopathy. So right away, if the child's been in the wooded area and there's something similar to a rash or flu symptoms, within that month, antibiotics should be started. And for kids under 8, amoxicillin works the best. Oral antibiotics works great. If the child's a little older, they use doxycycline. Doxycycline is really good with skin kinds of infections. If they're allergic, erythromycin or cephalosporins are good for this. They're treated for 2 to 3 weeks, not just a few days, to make sure it clears up. In general, people should be warned about the signs and symptoms of Lyme disease, and especially about the flu-like symptoms if it's shortly after they've been in a wooded area. And then preventative measures are the long sleeve shirts tucked, socks and closed toe shoes, and long pants with the legs tucked into the socks. So these are inflammation. Well, folliculitis is inflammation of the hair follicle. You may see it on someone's arm, where the back of their arm, where the hair follicles are. A furnicule is an infection of the hair follicle also, but it goes deeper, and it causes tiny abscesses or boils. And then a carbuncle is also an infected hair follicle that has pus, and it's a large boil. Can be anywhere on the body where there's hair, and it seems to be seen most often in warm, sweaty areas, like under the arms, the armpits. I've seen it there on kids. In the crease of their groin, or on their buttocks. Staph aureus is usually what causes it, but it also could be MRSA. So the lesions themselves begin as little red pimples, and they swell up. They get warm, swollen, and painful. Sometimes they'll leak the fluid, the pus, and sometimes they'll just swell up, and it's painful when they start swelling. The child will experience fever and chills, and of course, along with the fever comes a fast heart rate, and actually their blood pressure will drop. So the treatment is usually topical antibiotics, and the skin is cleaned often with an antibacterial soap. For for everything except for folliculitis. Well, no, I think they do it for folliculitis now too. Warm compresses. Because, that little tiny blister or the big blister, it will actually drain slowly. It'll make it burst slowly where it won't be so painful. And the warm compresses will promote the drainage of the lesion. If it's been diagnosed as MRSA, you'll have to do little packs that are soaked in diluted bleach and placed on the site. Either, depending on how serious it is, IV antibiotics may be given, but many times it can be treated with oral antibiotics. If the larger blisters do not burst on their own, they can be incised and drained. Endocellulitis, it's an infection in the skin, and it's in the underlying tissues. It's caused either by strep, staph, or Haemophilus B. Generally with the cellulitis, the child will have a tiny cut or a splinter or a scratch. It could also be a mosquito bite that they've scratched. And then it develops into, cellulitis is a pretty serious infection. The area becomes firm and swollen, and it's reddened. And many times there's systemic issues going on, the fever, the malaise, the increased heart rate. The picture there, although it doesn't look quite as bad, is a periorbital cellulitis. And we see that a lot with kids that get mosquito bites near their eyes. So whatever area it is needs to be rested. It needs to be elevated to reduce the swelling and edema. And by reducing the swelling, the discomfort is relieved. Over-the-counter meds such as Tylenol or Motrin can be used. Depending on how serious the wound looks, they'll either get oral antibiotics or IV antibiotics. Cellulitis are treated for a long time too, anywhere from 2 to 6 weeks, depending on how severe it is. Candida can grow in kids' mouth or in their diaper area. It's in the mouth. Generally, it's a child that has a real strong suck. It's usually a baby, and they have a real strong suck. So they actually will break away the normal flora in their mouth, and Candida sits on top of skin everywhere. So it now can flourish. It'll be on the tongue, on the inside of the lips, and in the gums. The baby will become a poor feeder and be very fussy. One thing, if you get a tongue blade and try to scrape it off, you can't. If it's in the diaper area, we'll call it a yeast dermatitis. And they're little red plaques with scallop borders, and there's usually a satellite papule with pustules surrounding the plaques. The area will be very red, almost like a burn. It'll itch and it'll be sore. So when you take the diaper off, it hurts the child. We see Candida with adolescents as well. And it's usually in the skin folds, maybe that rub together, especially in like heavy children, in the groin area where those skin folds meet. But it can be in any skin folds. We see it in the groin, in the gluteal cleft. Axilla is a big one, in abdominal folds. So for Candida, sometimes they need, what can cause it is, I should say, risk factors, is antibiotic therapy. The child could be immunocompromised. They could be using corticosteroids at the time, or it could be just irritation of the skin. The premature babies are prone to Candida. Newborns can get it from their mom's vaginal tract. And skin rubbing created in a warm, moist environment. So that could be using the wipes on the baby's bottom every time they go to the bathroom, instead of just using mild soap and water. So for the kids in the mouth, and actually for most of these, oral nystatin is applied. It's 4 times a day. Usually it's a syringe. And what really works well is if the parents would dip a Q-tip into the medication first and paint the lesions, and then squirt the rest of the medicine around the mouth, trying to hit all the lesions. But by giving oral nystatin, it'll also help with diaper rash or any candida anywhere else because it's oral. Usually you do it until the candida is no longer seen and 48 hours. So it may be 7 days, it may be 5 days, but you need to extend it 48 hours after it's resolved. If moms are breastfeeding and their babies have candida in their mouth, the moms should treat their breast the same way, rubbing the nystatin on their breast 4 times a day. Junction violet was the actually original drug for this, and now we use it secondary because it's purple, and they say given 3 times a day. Whoa. And usually it's just for 1 day. You can do it longer. I've seen prescriptions for 3 days. Junction violet is painted, it's purple on the lesions, and it actually can make the mouth bleed or the area bleed. It's very, very rough on the skin. It gets rid of the candida, but it's very rough. So generally saying 3 times a day is how it's written. We could wait and see if 1 time a day does the trick. It stains skin and it stains clothing. Diflucan is usually what's used on kids that are 6 months and older. It's a one-time treatment, and it works great, but we really always try the oral nystatin first. Some doctors just go through the drugs, the oral nystatin and then the junction violet, and that's not working, they'll go through the diflucan. For the diaper area, nystatin cream can be used. Sometimes the doctors will do both oral nystatin and nystatin cream. It's important to prevent the spread, proper hand washing, cleansing the nipples, and no direct contact with the rash. The babies will be uncomfortable, so comfort measures should be taken. And sometimes they teach the parents to give the medications. It's really important, especially to get all of the candida covered with the nystatin. So that's pretty important. So seborrheic dermatitis, cradle cap is called that. It's where the oil glands and the hair follicles get, there's an overproduction, and the baby's head will get kind of a yellow or white scales on it. To treat it, gently scrub the scalp with a mild pressure. You can use a baby hairbrush, you can use a soft toothbrush. Shampoo daily with an anti-seborrheic shampoo such as Selsun Blue, and then follow combing with a fine-tooth comb. After a while it'll go away. Baby shampoo that's no more tears makes it worse and sometimes causes this. Blepharitis is where the eyelids get swollen and it has oily patches, and bacteria will coat the eyelid margin near the base of the eyelashes. It's really itchy and cause redness and stinging and burning of the eyes to the child. So warm compresses for 5 minutes, 2 to 3 times a day is done. And a solution of warm water and the No Tears baby shampoo is used, and it's a 1-to-1 concentration, and you dip the cotton swab into the solution and rub it along the eyelid, and after a couple days that goes away. And then the otitis externa, inflammation of the ear canal. Sometimes they'll soak it with Burrell solution, but most of the time there's topical corticosteroids that are given. So acne is where the hair follicles become clogged with dead skin cells and oil. It can be anywhere on the body. We see it mostly on the face or the upper back. It's characterized by blackheads that are open, which is called comedones, or closed pimples, which are whiteheads. Propionibacterium acne, or you might see it written as P. acnes, is actually bacterial, and it's where the face is very inflamed. It can lead to papules, pustules, nodules, and cysts. The causes are genetic, hormonal changes for females, sometimes thick or greasy makeup, sweating, and working with grease such as fast foods. So some of the treatments are listed here. These are actually the more popular. Your book has a few others, but these are generally what you're going to see being used. The tetinoin, which is your retin A, is for mild to moderate acne. And they're to use like a pea-size amount, very small amount, rub it well after washing their face at night. If the patient uses it during the day, they need to know that their face could become flaky, irritated, and that really they may have problems with the sun, even from a small amount of exposure. So it's recommended that it's done at night. The benzoyl peroxide, which a lot of you are familiar, it's an antibacterial. It's used for mild to moderate acne. It's used once a day in the morning, and the patient should be aware that it can bleach any fabric it comes in contact with. Topical antibacterial agents are used for the mild acne, and oral antibacterial agents are used for moderate to severe acne, and they're used in combination with other treatments usually. The patient needs to be evaluated every 3 months to make sure it's working. It can be changed if it's not, and it's recommended that it's not used long term to prevent antibiotic resistance. The Accutane is probably the most serious one that's used for severe nodule acne, and it's only used after several other treatments have been tried. It works by decreasing facial oil. It is an anti-inflammatory, but it treats severe cystic acne. Being an anti-inflammatory, it will dry the face and anything it comes in contact with, so patients need to be aware of that. However, if the patient is experiencing severe headaches or anything outside of topically, any other symptoms, they need to stop taking the medication immediately and notify the dermatologist. It can cause elevated cholesterol and triglycerides, so monthly their labs need to be drawn along with the CBC and have it checked to make sure it's not elevating them too high. And it's very dangerous for a pregnant woman to take or to use Accutane. Therefore, there's a pregnancy test that's done prior to starting on the drug and then monthly before it can be renewed. And the patient needs to be on 2 types of contraceptives just to be extremely safe. So, education for the adolescent and for their parents is number 1, explain the treatment plan exactly and exactly every step that has to be done. Explain how important a balanced diet and regular sleep is. Encourage frequent shampoos, sunscreen, and protective clothing. Explain that tanning beds will only make it worse. You need to talk about the child's body image with the parents to get them on the same page and to support the child. Explain that before they start the medication, if it's ascertained that they will have cholesterol and triglyceride labs drawn, and then as prescribed they need to be repeated and the importance of it. Explain the dangers of getting pregnant and be very strict about that. Explain that the patient needs to clean their face with mild soap and water regularly. Tell them when they take the medication or put on the medication, assess for redness, swelling, fevers, and pain, and to report it. And they can take an antipyretic. Complications is an infection or a cellulitis. So, when we talk about skin, we have to talk about things that can happen to our skin. And burns is probably one of the worst things that can happen to the child's skin. We'll talk a little bit about burns in general, but the important part of this piece is the skin, what happens to it, and how it's treated. Age and development actually has a big part with children and burns. You know, children are generally curious, and as they start moving around, they're into touching and they want to explore, and they can actually cause their own, burn or get involved in burns. Children under the age of 5 and children 15 to 19 are at the greatest risk for burns. And the cause for a lot of them is hot liquids and steam. And then next would be electricity. Both male and females are equally at risk for burns. One is not more prevalent than the other to have burns, except we do know that boys are more risk takers than girls. Location plays a role in causing burns. The kitchen in the home is equipped, with hot utensils. There's a burning stove, hot cooking oil, and other substances. If proper care isn't taken to protect the child from touching these things, they will, be at risk for a burn. The environmental factor, smoke inhalation, comes under environmental risk factors for the child. Or too much exposure to the sun puts children at the risk for a sunburn. Along with this, inhalation from vehicles, cigarettes, fires, chimneys, and a few more can lead to burns of the airway, which is very harmful. Abuse and neglect, unfortunately, abuse falls into the category of intentional injury to a child. And burns is one of the ways that the children are intentionally injured. Neglect is that child that might be exploring, learning to play with matches, and no one's, keeping an eye on them. And that goes along with lack of supervision. So the thermal burns result from contact with hot substances. It includes flames, hot liquids, hot solid objects, and steam. Oil-based liquids such as grease and cooking oil have higher boiling points, and they cause deeper burns than scalds with water or other liquids. Radiation burns can result from exposure to radio frequency energy, or things like sunlight, tanning booths, x-rays, or nuclear emissions. Chemical burns kind of falls into that category as well, I think, but no. Chemical burns destroy tissue and continue to do damage up to 72 hours later unless it's neutralized. Causes of chemical burns are strong acids, alkalis, and organic compounds. For acids, it's common in household cleaners such as rust removers and bathroom cleaners. And what they do is they cause protein coagulation, which results in less extensive injuries, but burns nevertheless. Alkalis, such as oven cleaners and fertilizers, cause deeper burns. Organic compounds that cause chemical burns include gasoline and chemical disinfectants. We don't have smoke inhalation up here, but smoke inhalation also can cause burns, of facial burns, burns of the lips, and burns of the throat. And then our electrical burns are classified as low voltage or high voltage. And electrical injuries can cause death by triggering ventricular fibrillation or paralyzing respiratory muscles. Also, when we talk about burns from electrical currents, children could chew on the cords and get an electrical burn, or play with an electrical outlet. So the first picture shows you the different layers of skin that is destroyed by burns. The superficial partial thickness, which used to be called first degree, shows that it just destroyed or injured a portion of the dermis. Where the deeper partial, which is more similar to the second degree burn, involves destruction of the epidermis and the upper layers of the dermis, and sometimes injury to deeper portions of the dermis. And then, of course, the full thickness is third degree on, and it involves total destruction of the epidermis and dermis. And it can also destroy underlying tissues, muscles, and bones. And so the picture on the right kind of shows you that a superficial is painful, there's redness, it will blanch though, and there's no blisters, no edema. The partial thickness will blister. It'll be somewhat moist and very painful. And then the full thickness actually is very dry, and it'll be discolored, sometimes black, and there's no pain because there's no sensation left. So just like adults, we use a percentage scale, the rule of nines, for determining how much of the child's body that is burned. We use it for adults, but the rule of 9 varies between infants and adults because infants' heads are proportionately larger compared to the adult. The child is more similar to the adult, actually. So there's a lot of common methods used. One is a Lund-Brauer chart, and the other is the palm method. The Lund-Brauer method is recommended because it corrects for the larger head to body ratio for children and infants. So I actually wrote it out for you, what each percentage is. So one thing to keep in mind is that the chest and abdomen amount to the front torso. So you get one number for that. The upper and lower back amount to the back torso. So I gave a little example on the bottom of the infant. If the chest and the right arm of a baby were burned, we would say that 18% of the body's surface area is burnt, according to the pediatric rule of nines. And on the right side is the information for the child, still a pediatric patient, but not an infant. So once again, the chest and abdomen amount to the front torso, and the upper and lower back amount to the back torso. So that you could calculate it. So basic nursing care upon admission, this is just very basic. Stop the burning process. Remove burnt clothing and jewelry to do that. Right away you cut away their clothing. And right away you can, especially for the superficial and even the first superficial partial, you want to put cool water soaks on the burns. And if it's a chemical burn, you want to flush the water. Always assess the ABCs. Always make sure the patient is breathing. That's the most important thing. The child's wound could be covered with a clean cloth. And once everything settles down, the wounds can be cleaned with soap and water. The children usually come in hypothermic, so keep the child warm. So some little bits of, I guess, little pearls of knowledge is a delay in growth may occur after a burn injury, mainly because the child faces a lot of contractures. An immature immune system presents an increased risk of infection for infants and young children. Infants and children are at an increased risk for protein and calorie deficiency, mainly because they have smaller muscle mass and less body fat. The nurse needs to check immunization records as soon as possible for the need of a tetanus injection. And range of motion exercises should be started the day of the injury. Those are all little pearls of wisdom that every nurse that works in a burn unit or sees a burned patient in the ER need to know. So burns. We have the superficial burn, which is similar to a sunburn. And it just generally involves the dermis, which appears pink and red. It's painful, but it doesn't blister, and it heals in about 7 days without scarring. And a good example, of course, is the sunburn. Now, children under 6 months old cannot use sunscreen, so they need to be protected by clothing and need to be kept away from direct exposure to the sun. Children 6 months and older can have sunscreen. It needs to be applied 30 minutes prior to them being in the sun, and then frequently like Q2 hours. The superficial partial thickness burn used to be called the second-degree burn. And actually, with the new terms, the second-degree burn has been divided to not as bad and bad. So the epidermis is destroyed or injured, and a portion of the dermis may be injured. It extends superficially into the second layer of skin. So if you have a patient that has superficial partial thickness, they usually will have blisters, and they usually will have pain. So first thing you will do is move away from the source of the burn and remove any clothing from around the burn. You'll flush the partial thickness burn with cool water for approximately 15 minutes and then pat dry with a clean cloth. Do not open any blisters that may form, and do not use ice to cool the burn. You can soak a clean cloth with cool water and apply it to the burn as a compress, and that works really great to relieve pain. When the order is given, you can bandage the burn with a nonstick bandage or a sterile cloth to protect bacteria and foreign debris. With burns, infection is the source that actually can kill a child. So the deep partial thickness is where it's the destruction of the epidermis and upper layers of the dermis. However, there's injury to the deeper portion of the dermis. So another way to say that is it extends deeply into the second layer of skin and can quickly evolve into the full thickness, or what used to be called a third-degree burn. The skin will have blisters, it'll look mottled, and it'll be red and white. There's moderate edema now, and it blanches. It's very painful and sensitive to temperature changes and light. The healing time is now over 21 days. The nursing care includes medications to treat pain, swelling, and fever, medications for the pruritic, I don't want to say lesions, but for the burns that become very pruritic, antibiotic therapy to prevent an infection, debridement, which is putting a patient into a hydrotherapy tub and removing any dirt and the dead eschar off of their bodies, and you pull it off so that the new skin can grow, or any objects that are from the wound. Sometimes if it's a house fire or something, the children will have debris from the house itself. This type of burn generally requires skin grafting, and they usually try to use the child's own skin. Sometimes they'll need a sclerotomy, which is where the area gets very swollen from the burn, and they need to make a cut along where the dead tissue is to decrease that swelling and get the fluid out. Of course, there'll be burn protocol wound dressings, IV therapies, and blood tests to check for infections, and they check their electrolytes. There's CBCs, just to keep the child healthy. Usually blood gases too. Okay, so for full thickness burns, this is definitely what used to be called the third-degree burns. All layers of the skin are destroyed, and the damage may even penetrate the layer of subcute fat underneath the skin. It's not painful when it's touched because the nerve endings are destroyed. As the burn heals, the sensation will return and pain will return. The sweat glands, nerve endings, and hair follicles are destroyed. The wound looks waxy and white. Sometimes people say it's gray and leathery or charred and black. It's very dried out looking, and there's no blanching. It heals in weeks to months, and scarring is present. And usually, almost always, this requires skin grafting to close the wound. And the deep full thickness. And it also is a destruction of all the dermis. And in many cases, you'll see that the underlying tissue, muscle, and bone are destroyed. These burns often occur with flames or electrical and chemical injuries, and the wound is charred. It is blackened, it's depressed, there's hardly any sensation, and it's actually the sensation's completely destroyed. It heals in weeks to months if the patient survives the burns. There's definitely scarring. And the wounds will usually need excisions to drain them. Again, grafting will be done, which should decrease some of the new pain and the length of stay. And the grafting will accelerate recovery if the patient's cooperative. Amputation is usually warranted when one of the extremities is involved. There's always vascular changes, and the circulatory disruption occurs where the burn site is immediately after the burn. So care for burns, and this is probably the more serious burns, or what they call major burns, is number one for any kind of burn is to maintain an airway and ventilation. So ABCs is most important. Airway is number one. Always remember that. These kids can have 100% humidified oxygen. You will take a look at their vital signs and monitor their cardiac output regularly. It may be Q2 hours when the first couple days that they're in the hospital. An IV will be started away from the burn site with a large bore needle, because a lot of fluid's going to go in quickly, and also blood products later on will be administered. And many times they start more than one IV to get started, and eventually they'll go to surgery for a line. But at this point, they don't want any risk of infection. It's important to prevent hypovolemic shock. So they call this fluid replacement. I'm trying to think, there's also another name for it, but it's important in the first 24 hours. And generally they use an isotonic solution such as 0.9 normal saline or lactated ringers. And they do that during the early stage of burn recovery. After about 24 to 48 hours, they'll add some albumin or plasma to aid in the recovery. The urine is measured, strict INO is done, and they want to maintain a urine output. For kids under 30 kilograms, it's 0.5 to 1 milliliter per kilogram per hour, and over 30 kilograms, it's 30 milliliters per hour, and it's recorded hourly, and it's very important because if they have a decreased urine output, it can be a sign of septic shock. So this is, we're opening up these fluids. They're probably at 2-time maintenance at this point, and so this needs to be monitored closely. They're going to septic shock. Will observe for it constantly, and what we're looking for is some signs such as confusion or an increase in capillary refill, or a sudden spiking temperature, mottled cooled extremities, tachycardia, tachypnea, decreased urine output, decreased bowel sounds, everything's slowing down. Pain is managed. Never give an IM or sub-Q shot to a burn patient. Only IV opioids are used. Usually it's morphine, but it could be fentanyl as well. When giving these opiates, remember to watch for respiratory depression, and administer pain medications prior to dressing changes or any painful procedures such as positioning the patient. You can also use non-pharmacological methods such as music therapy or guided imagery. Believe it or not, preventing infection is so important. So follow whatever's prescribed and sterile precautions when doing dressing changes. Reverse isolation is pretty important. Plants and flowers are restricted from the area, and so are sick visitors. The child needs to be changed in position frequently to prevent a contracture, but more important, to prevent pressure in one area that can cause an infection. Visitors are limited. Reverse isolation is prescribed. Watch for signs of infection. The child being in reverse isolation should have their own blood pressure, cough, and thermometer. They should get a tetanus shot if it's indicated, and IV antibiotics will be given. You'll never know how important nutrition is until you take care of a burn patient. They can heal so much more quickly if they have the proper nutrition. So the calorie intake needs to be increased because of the metabolic demands. Increased in protein to prevent the tissue from breaking down and to promote healing. Usually this is done enteral feedings or PN feedings because we don't want them to burn calories digesting foods. So they already have a decreased gastrointestinal motility, and we don't want to cause anything to burn more calories. Vitamin A and C will facilitate cell growth, and zinc will help wound healing. Mobility is really important. Their body needs to be put in alignment constantly. Extremities will be splinted. The position needs to be changed frequently to prevent contractures. Active and passive range of motion is done from day one, and even after they receive skin grafts, passive and active range of motion is done. As soon as the child can get up and walk, physical therapy needs to be notified to come in and assist with this. Pressure dressings are used to prevent contractures and scarring, and the heels, sacrum, and back of head are looked constantly to see if they're getting any pressure sores. Psychological support for the child and the family is important. First of all, body image for the child, is something that he's going to have to learn to cope with, and you're going to have to be a big support. Make sure that you give developmentally appropriate support for the child. Prepare them for everything that's happening, and prepare the families, and remember to use family-centered approach. Referrals should be made, and you should facilitate them and make sure that the referrals are received by the correct people, such as physical therapy, occupational therapy, infectious disease, nutrition. So wound care. Dressing changes probably is the most painful thing for these children, and it's something that they dread. And actually, I think the nurses dread them just as much. So before, half an hour or so before, the child is pre-medicated with an analgesic such as IV morphine. They're also given, some Benadryl or something like it for pruritus. Many times, as soon as you take off the old dressing, they want to scratch at their skin. The old dressing will be removed, and at the same time, check for different odors as if there's an infection or dead skin. Check for drainage and discharge. There'll be an order on how to clean the wound. Generally, the child, it's kind of flushed off all the, ointments and the Silvadene or whatever's on the child to start with. And a lot of times they'll use a mild soap and water. The child will go into a debridement tub called a hydrotherapy tub, and it's warm water, and many times they keep the water running, and it cleanses the wound itself. It's done once or twice a day, and in this tub, mild soap is usually used gently to wash the burns, and the dead skin usually will peel off by itself, and then the body is rinsed with tepid water. Sometimes at first, while they're in the hydrotherapy tub, they can do range of motion, and it's a little bit easier for them to do it in the water. And then you have to be careful. We don't want these kids to get hypothermic, so you have to monitor for coldness for them. So watch very closely for the wound infections, and the wound infections are listed. You monitor for odor, drainage, edema, or discharge. Monitor for a temperature and an increased heart rate. Many times wound cultures are done like once a day or once every other day to be sure they don't get infected. Antibiotics will be IV antibiotics, sometimes triple, and lab results. Every day the children will have blood work done. And always maintain a surgical aseptic technique. These hydro tubs have a special lining in them so that the child doesn't get infected from being in a tub that someone else is in. We always have to watch for shock with these children. So we watch for confusion, increased capillary refill, a sudden fever. The child didn't have a fever, now they do. Definitely a decreased urine output. And your book has a decreased bowel sounds. So to prevent shock, we're giving their IV crystalloid solution for 24 hours first. We follow it with the colloid solutions, which is your plasma blood products. Also, can't think of it. Plasma, blood products, and albumin. I just couldn't think of the word. They're put on strict INO. Everything that goes in is measured. Labs are watched for, and they watch for anemia and infection. If they become anemic, they're not going to heal. Vital signs are monitored because that can tell us if their temperature's going up, their heart rate's going up, that they may be going into shock. Assess their senses. Is the pain sense coming back? And always assess for capillary refills. many of these kids end up with some pulmonary issues, and part of it's because, at first they're in their bed and, they have to cough and deep breathe. Sometimes they go to surgery several times. But what's really important is sometimes these kids, where if it's a house fire, will be in an enclosed room with the fire, and they'll have smoke inhalation, and it doesn't show up right away all the time, and sometimes they don't even look a lot different. So usually the second day or so, you'll see an increased respiratory rate. Their voice will become hoarse, and they'll go into shock, altered mental status. You'll see burns on their head and neck. Sometimes singed nasal hairs will be an indication that you have to watch them for inhalation burns. And sometimes you'll see burns in their mouth. We watch for inhalation injury because of what they've been through, but unfortunately, it's really tough to intubate them if their throat, their esophagus, their trachea, are already singed. So they will be intubated if they have a compromised upper airway, and they will be put on a ventilator to rest them and help their gas exchange. However, it's one of those situations that we wait until we think they're going into shock symptoms, because we don't want to cause more trouble to their airway. Many times these kids will end up trached just because it's a better way of intubating them, and they'll be on oxygen. We talked a little bit about skin grafts. We're not going to go into a lot of information. Just know that many times they do an allograft, which is the donor skin is taken from the child themselves on a part of their body that wasn't burnt, and it will be transferred until the burnt part. Sometimes they do mesh grafting if there's not enough donor skin. Now they're using cultured epithelium, which is pretty cool, and that's because graft sites are sometimes limited. Sometimes so much of the child's burnt that that's all that they have to go on. Allografts are human cadavers, and they're used. We worry about rejection to the allografts, but they are used. A xenograft is from pigs. It's the skin that's most similar to humans. And now there's some synthetic grafts that can be done for the partial thickness burns. After the child's been grafted, immobilization of the graft site is important at first. So they'll be a stockinette will be put over their body, and they'll be put in splints, but the splints need to be taken off every hour, and passive range of motion needs to be done. And when they're first grafted, whatever's grafted needs to be elevated. Medications that are generally used for burns are, the topical ones, the Silvadines, the megphenonite, acetate, bacitracin, and then for pain, it's morphine, or sometimes for sedation, it's fentanyl. These are used to help the child relax, especially before or after the hydrotherapy or dressing changes. I wanted to put a little bit about the eschar-otomy because that skin, and what happens is the skin gets really tough and rigid, and meanwhile underneath the tissues are trying to become edematous, and the fluid is building, and you will see an increase in interstitial pressure, and it will compromise the vascular flow, so the area will start becoming duskier and duskier until it's cyanotic. So what they do with these situations is they actually cut into the skin along the lateral aspect of the extremities, and the incision goes completely through the eschar, and therefore the area can be opened and all the fluid can escape, and the circulation can return to somewhat normal. We have to talk about maltreatment of children, and I've been trying to include little things with each thing we talk about instead of doing one whole day of maltreatment. We will talk a little bit. Maltreatment is the other name for child abuse, and it's the preferred name this day and age. So burns is really one of the ways that these children are abused. And what you look for is if there's a shape to the burn that the child has. It is important to keep in mind that children instinctively withdraw from pain. I think we all do. So when you look at areas that are burned, there's certain giveaways that this was done intentionally. So it could be splashes, uneven burns, and sometimes burns on the hand. The one well, we'll go on, it's up on the next side. Scalding a child with hot liquid is really very, very common. And sometimes children are scalded by being set into a tub or having liquids thrown or poured on them, or made to drink something scalding hot. Sometimes there's objects that you can see that are burnt into their skin, and this is considered branding the child. It could be a grill or electric heater or an element of the stove. They put their hand on the stove, or an iron. The jackknife position is when someone's lowering a child into a scalding hot bathtub, and only they pull their knees up because they don't, they know it's hot. Only their buttocks and genitalia can be burned. But sometimes they're held down into a sitting position, and you'll see that the child has a donut shape because he's all the way at the bottom of the tub. So there's a donut shape all around that area. Another common type of abuse is where the child's hands or feet have been immersed in hot water, and it gives the appearance of gloves or socks. When burns are pointed or deeper in the middle, this is a very definite indicator that the child's been abused. Hot liquid was poured on them, or a hot object, and a poker like the one you use for your fireplace can do that. Cigarette burns are somewhat difficult to diagnose, but generally they're found on the palms of the hands or the soles of the feet. And you'll see it because there'll be little blackness all around the circled area of the burn. They call it charring. And you could see the picture where they're immersing the child and he's pulling his legs up. You can also see right next to it B. It's not very clear. It's the best I could really find. That wasn't too gross. Where it surrounds the body, the burns. And then the child with his hands burnt only. So preventions from burns, when a child's going to go home, you feel kind of bad saying this, but there needs to be smoke alarms that work, and they need to be tested. And the family should have an escape plan if the house, caught on fire for the future. And there should be 2 ways out of every room, and the family should decide a central meeting place outside. Prevention really also cooking with care, turning the pots, the handles from the pots away from where the child can reach it. Don't leave, the child in the kitchen unsupervised while the stove is on. Always check the water heater temperatures, and actually when babies go home from the hospitals, newborns, they're encouraged to turn down that water heater. And the thermostat of the water heater should be 120 or lower. Make sure that they say that it's really hard for children to get away from water that's too hot. So some people will actually put a constant a thermostat setting to control the water temperature on the hot water tank. And always test the tap water to see if it's hot. So, the discharge teaching, I don't have written down for you, but I think you guys can probably know that a child that goes home with a burn needs to perform their range of motion exercises and to keep up with their physical therapy to prevent their contractures. The family needs to assess the wounds just as you did and provide wound care. Teach appropriate safety measures. And teach the family to avoid sun exposure between 10 and 3 o'clock, and that the child should wear protective clothing, and if they're old enough, they can have sunscreen. I know that this was a lot of information for you. Actually, we ended up doing not only just the skin, but the burns as well, and kind of knocking that out. So you'll have your information available to you for ATI. So please do your take-home quiz, and good luck with it.